Morning, everybody. Thanks for coming. My name is Mike Krainock, and I'm going to talk today about molecular residual disease and circulating tumor DNA. Just out of curiosity, how many of you guys kind of work in cancer and are becoming familiar with ctDNA's emerging role in cancer treatment? Cool. Okay, great. So I'm not supposed to be here today. So our academician, our coordinator, or excuse me, our collaborator, was not able to make it due to COVID lockdown restrictions instituted at his facility. So thank you for allowing me to sub in kind of at the last minute. But full disclosure, I do work for the company, and I was kind of called in from the bullpen to fill in for our missing colleague. So circulating tumor DNA is pretty cool stuff. So we know that cancers proliferate and progress pretty quickly. Well, as they're doing that, cells are dying and turning over. So they're undergoing apoptosis, they're undergoing necrosis, and they're actually kind of showing their hand to us in doing so. So they're leaking out their genomes to a place where we could easily kind of interrogate those genomes, and that's the peripheral blood. And there's a few different really interesting high utility ways to do this. One way to do it would be to know what you're looking for and kind of assay the blood for targetable mutations. That would be really relevant for patients with advanced disease, where you're looking at targeted therapies. And then of more interest to kind of, I think, this group is probably the other kind of major utility indication, which would be the detection of molecular residual disease. So you've done a curative intent resection on an early stage solid tumor. You see nothing on your scans, you feel no cancer, you see no cancer. Is that patient truly cured? And this tool is emerging as an answer to those types of clinical questions. So before we talk about the kind of the preliminary data set that I'm up here to talk about, I wanted to introduce kind of our published clinical validation data to kind of set the stage and the rationale for the stage 1 data I'm going to share with you today. So we do quite a bit of studies. This was one of our early clinical validation studies in colorectal cancer. We do these studies across really all solid tumors ongoing currently, but this particular one was in colorectal cancer, stage 2 and 3 primarily, published in JAMA Oncology in 2019. And we're looking at 795 samples across 125 unique patients and drawing circulating tumor DNA assays at a pre-surgical time point, post-op day 30, and then every 3 months for up to 3 years. And what emerged from that data that really kind of got the field pretty excited about the technology was that we outperformed the typical clinical pathological risk factors that we use to make adjuvant systemic therapy decisions. So you can see when you look at the post-op day 30 time point, so this is a patient you've resected, trying to make a decision on adjuvant chemo. The Signatera test was a statistically significant independent predictor of recurrence risk, with positive versus negative patients being separated by 7.2-fold. If you looked at patients after adjuvant chemotherapy, so patients who did get systemic platinum, if they were still positive after that, they had a 17.5-fold increased risk of recurrence, which is really getting predictive at that point. Interestingly, in patients who were positive after surgery, got chemo and cleared on treatment, none of those patients recurred in this study with a follow-up of 12.5 months. And then in the surveillance time point, you can see that in patients who have finished definitive treatment, they're undergoing serial monitoring with CT scans and CEAs in this case. When you're longitudinally positive in the surveillance setting, it's really a countdown clock to recurrence with a hazard ratio of 43.5. And the other kind of impressive piece of this were the lead times. So you would molecularly recur on average 9 months before you recurred on a CT scan, all the way up to 16.5 months. So asking, can we exploit that fact and can we use that as a lead time advantage? So knowing these strong data in stage 2 and 3 disease, we kind of just asked the question, well, what about stage 1 patients? So we have a big database, and we asked, well, how many stage 1 patients have we tested, and really, what is their anytime positivity rate in that data pool? So we know that, you take a patient with stage 1 disease in the operating room, your expectation is you're going to cure them of their disease surgically, but we know that there is a group of stage 1 patients who really are understaged by classic TN&M pathological risk factors and end up recurring and succumbing to their disease. So that was kind of the rationale to ask, well, as a signal finding mission, how often have we found a signal at any point in a stage 1 patient who's been resected? So this was a commercial database pool, a little bit of the assay background. So this is a personalized and tumor-informed multiplex PCR assay. We call it Signatera. We take a piece of the patient's cancer. That can be from a preoperative biopsy. It can be from a surgical resection specimen. We take a sample of whole blood at the same time. We do a whole exome sequence on the cancer. We do a whole exome sequence on the nucleated peripheral cells, and then we do a comparative sequencing analysis and select 16 clonal passenger mutations that are unique to that patient's cancer only. That's kind of the methodology behind the test. We had applied that to 122 stage 1 CRC patients that we found in our commercial database. 75 of those folks had colon cancer, 47% had rectal cancer, 52% were males, and 47% were females with an average age of 62 years. So a couple things about the data here. This is truly high-level data. So because this was a commercial pool, we don't, have lead times. We don't really have anyone following a standardized testing schedule. So this is kind of tip-of-the-spear type of data that I hope kind of gets people interested in doing those types of studies. But this is what we found. So in colon cancer, 7 of 75 patients were positive at some point after curative intent resection for an MRD signal. In rectal cancer, 7 of 47, or about 15% of patients were positive at some point. For CRC, total being 14 of 122 patients, or just over 11% of patients. Interestingly, when you looked at TAMIS versus LAR or APR, you saw a spread of 19.2% versus 9.5%, which I thought was pretty interesting. I know we have some colorectal surgeons out there in the crowd today. This didn't quite reach statistical significance because of small n, I think, but I think with a larger series, we might get there. So kind of an interesting question to ponder. And with colon cancer, really didn't have too many local excisions to speak of, but 7 of 10 after segmental colonic resection had a molecular recurrence as detected by the Signatera assay. Just 2 brief use case examples where we did have kind of more complete clinical data. So this is a patient with colon cancer who had her operation. This was a sigmoid colon cancer. She had a lower anterior resection as represented by that green dotted vertical bar there. You can see at the time of diagnosis and immediately postoperatively, her CEA was actually below the limit of normal, but her ctDNA was positive post-op. At the time of the positive ctDNA, she had indeterminate findings on her CT abdomen pelvis, but given the ctDNA was elevated, they did a CT chest and they found multifocal pulmonary metastatic disease. This patient was then started on FOX, and you can see it's interesting here that the CEA and the ctDNA are moving in opposite directions. So you would think that she was responding by CEA, but the true destiny for this patient, unfortunately, was pretty rapid progression as reflected in her ctDNA kinetic profile and then shown on scans later. This is a patient who had a TAMIS for a low rectal cancer, 2 to 3 centimeter rectal cancer. After her TAMIS, you can see that her ctDNA did initially clear. Again, CEA at the time of diagnosis was negative. And then she turned positive for circulating tumor DNA. And this positivity or molecular recurrence occurred about 10.5 months before she recurred clinically and radiographically with a local recurrence in the pelvis. So it begs the question if this fleshes out with more research that this is an early indicator for local and regional recurrence after TAMIS, does that identify patients who would benefit from early step up to LAR or APR? And so I think, again, this is a stage 1 cohort. I thought it was interesting, we found an anytime positivity rate that's about what we expect for clinical recurrence rates, so about 11.5%. We know that stage 2 and 3 positive Signatera is a really significant predictor of recurrence. We have no reason to believe it's not true for stage 1 disease. So I think we can potentially use this tool to identify stage 1 patients who are at high risk for recurrence and potentially think about ways to move the needle for them or approach them with curative intent after they've been resected. And I think TAMIS is kind of an interesting area to really focus in on because it's a unique situation where we really have no lymph nodes. I think any piece of molecular data would be useful there to identify patients destined for a local regional recurrence. And so really I hope that this data has been something that kind of gets you interested in doing this type of work using this commercial pool and our previous peer-reviewed articles in stage 2 and 3 disease to kind of whet the appetite for stage 1 trials in this cohort. Thanks.